I was very pleased, indeed proud, to be asked to come and do this talk to open the sepsis session. I was slightly less pleased when I saw the title I was being offered, given that I come from central London. We see a fair bit of meningococcal disease. We see very occasional malaria. I've never seen a case of dengue. And my satisfaction at being asked to do this talk was also affected by noting that several major world authorities in both malaria and dengue are either speaking or helping us chair. So what I decided to do was take a slightly unusual route through these subjects, and I think we can make some useful comparisons. And the route I'm suggesting goes via Sunderland in northeast England, goes via southern Scotland, Leith near Edinburgh, and then to the south of the US before heading off to the tropics. So we're going to start in 1831, and this is a publication from Sunderland in the UK, which was had the news item that the cholera morbus was extending itself to an alarming degree in Sunderland. You may wonder why I'm talking about cholera when it's one of the few diseases not included in my title, but we'll come to that. So cholera causing trouble, and like all things in the UK, the weather gets the blame. It was considered to be attributable to the present unseasonable state of the weather. And these are the mortality statistics that were produced at the time, and there were hundreds of people dying in Sunderland and Newcastle at the time from cholera. And these kind of crises precipitate young enthusiastic doctors rushing to the scene to try and help out. And a couple of famous doctors joined the group, including John Snow, but well before he became famous, and this chap, Thomas Latter. And the work that Thomas Latter undertook in Sunderland at the time got him invited to write a letter to the Lancet about one particular case. And like all good research, it concerned a clinical description. And I'm going to take you through that. And please note the quality of the written English is far better than anything you'll see in the Lancet these days, I think. The lady in question had apparently reached the last moments of her earthly existence. I feared I should be unable to get my apparatus ready ere she expired. Having inserted a tube into the basilic vein, cautiously, anxiously, I watched the effect. Ounce after ounce was injected, but no visible change was produced. I thought she began to breathe less laboriously. Soon the sharpened features and the sunken eye had fallen jaw, pale and cold, bearing the manifest impress of death's signet, began to glow with returning animation. The pulse, which had long ceased, returned to the wrist, at first small and quick, but by degrees it became more and more distinct, fuller, slower, and firmer, and in a short space of half an hour, when 6 pints had been injected, she expressed in a firm voice that she was free from all uneasiness and actually became quite jocular, and fancied all she needed was a little sleep, and sent me away, effectively. At that stage, her extremities were warm, and every feature bore the aspect of comfort and health. This was the first human infusion of saline, and he has the conclusion, which I don't think you'd get past a reviewer these days. I think I can adduce sufficient proof to the unprejudiced, not only of its safety, but of its unquestionable utility. I have never yet seen one bad symptom attributable to it in a single case report. It doesn't actually make too much of the fact of what happened to this woman. Seeing this dramatic response, he left her in the care of a house surgeon. And that should ring alarm bells for all of you. And in fact, not long after he left, she started vomiting and purging, and soon returned to her former state. He wasn't told about it, and she died some 5.5 hours after he left. It doesn't shake his confidence one tiny bit. He had no doubt the case would have issued a complete remission had the remedy been repeated. So this is the first example of someone being a passionate advocate for aggressive fluid resuscitation. So the next point on the globe then is Nashville in the mid-20s. This is Alfred Blalock, who you'll know for his shunt, but he also did a lot of work about how the circulation was regulated, and famously used to bleed dogs. And this is the original paper from 1926 about the cardiovascular response to hemorrhage. and beautiful handwritten graphs, and it's plotting two things: the hemoglobin concentration in the interrupted line and the cardiac output in the solid line against change from baseline. And each of these interrupted vertical lines represents a hemorrhage of 1% of body weight. And they're done at 2 to 3 hour intervals. And in this group, there's no fluid replacement. And what he sees is that by the time you've taken 3 or 4 of these bleedings, the cardiac output is starting to fall, and the animal is showing signs of shock. It's dyspneic, it's weak, and it's pale. And interestingly, there's evidence of venous desaturation, which we'll come back to. The real information, though, is in the other group, the control group, if you like, where the blood was taken out but replaced with saline. And here, the dog, is very much more tolerant of volume loss, getting to the 4th bleeding before there's any real evidence of shock. The hemoglobin concentration falls more rapidly, but there's this huge increase in cardiac output. We would all understand that as a compensatory mechanism. Interestingly, at the time, it was interpreted as some untoward effect of a drop in hemoglobin. Okay, so now we can actually talk about the diseases I'm supposed to be talking about. Meningococcal disease. This is pretty severe meningococcal disease, someone on a high-frequency oscillator, on a hemofilter at the same time, receiving some coagulation support, multiple inotropes, and obviously a terrible coagulopathy. We have to run through some of the simplified pathophysiology. Here are the bugs. They have stuff on the surface that makes neutrophils angry. They change shape and degranulate and stick to stuff. It makes endothelium angry. It becomes sticky and leaky. And the same things activate monocyte macrophages to produce secondary mediators, pro-inflammatory cytokines. And we're all kind of familiar with that. One of the key steps in that process is the binding of lipopolysaccharide endotoxin to complexes that take it to a receptor, toll-like receptor 4, and elsewhere in this conference, the impact of different functional polymorphisms of that receptor are being discussed. We know that if you're exposed to endotoxin, you produce particular profiles of these pro- and later anti-inflammatory cytokines. And some of the consequences of that we can now look at. This is a graphic we'll keep returning to try and summarize the pathophysiology of the conditions we're talking about. Endothelial dysfunction being one significant component. And endothelial capillary leak is at least part the result of loss of charged particles, heparin-like molecules, glycosaminoglycans on the surface. Here on the right-hand panel is a healthy endothelium in culture, and here is after exposure to inflammatory insult, completely lost, and that means that the charge properties are changed, and you're less able to resist albumin passing through the endothelium, hence capillary leak. So we know a little bit about that. We also know a little bit about thrombosis and bleeding, and this is a huge topic, which we're going to summarize in 2 slides. The first is this one, and perhaps the most important areas to think about if we're talking about thrombosis and hemostasis and sepsis are tissue factor expression, which activates factor 7, both on monocytes and endothelium in response to these cytokines, but also disorder of breaking down clots. So inhibition of fibrinolysis, plasma activator inhibitor 1, again, functional polymorphisms of this molecule influence outcomes. So 2 really key sites. Some of what we know about coagulation in sepsis is influenced by the recent studies of the recombinant human activated protein C given to patients. And this would seem to be a very good choice of molecule to help us with this process, in that it causes some inhibition of tissue factor expression. It's anticoagulant, so it stops flow through the coagulation pathway and consumption of clotting factors. And it also promotes fibrinolysis. So it hits all the right marks. Trouble is, when you give it to children in severe sepsis, it doesn't improve outcome. And many of you in this room were involved in this study of 480-odd children around the world, and we saw no improvement in either mortality or the organ failure scores, completely superimposed curves for organ failure resolution. So we know a lot about it, but it hasn't helped us into therapy. Perhaps the third area then to combine is what's happening to the heart in this process, myocardial depression. And we know some of this from Perillo's experiments in the late 80s, giving endotoxin to dogs and to medical students, I understand, in which order we're not quite clear. And the observation he made was that the normal, healthy, muscular, vigorously contractile heart changed in property in the majority of septic shock cases, where it became baggy, less vigorously contractile, but larger. And in that dilatation, it was able to maintain stroke volume, as shown in these panels. So there's an adaptive response of the heart getting bigger in response to less effective inotropic function. Why does this happen? Well, for all sorts of reasons. Nobody can answer this properly for us. All of these things play in. There's been a lot of focus on IL-6 recently, but that's the latest of a long series, and we're yet to understand. But it's a combination of factors. But it is a dominant part in what's happening, certainly to meningococcal cases. The Guy's group in London present these data. I think this is quite informative. The same are true of other transport teams. But now the vast majority of deaths from severe meningococcal disease, at least in the UK, occur in the first 6 hours of intensive care treatment and resuscitation from unresuscitatable shock. It's not late complications of multiple organ failure. It's just you can't ever get them perfusing. And perhaps we'll understand this a little better now there are newer techniques to allow rapid early assessment of cardiac output. This is a machine we particularly like. It's a non-invasive and has no disposables, ultrasound cardiac output monitor. And that can give us some data. This is Joe Briley's work from our unit, showing cardiac index on the x-axis and systemic vascular resistance index on the y. And this is after fluid resuscitation in the first 4 hours of these patients' episode of septic shock. There is a huge range of the hemodynamics the patients present with. It's not as simple as Perillo would have us believe. Interestingly, the allocation to the different patterns of septic shock is dependent on the cause of the septic shock. We don't have time to go into that in more detail. So from all of these things we know about the pathophysiology, how does that help us manage these cases? Well, it doesn't. In fact, billions of research dollars have been spent investigating all these candidate molecules. When I made this slide, originally activated protein C was thought to work in adults, has since been shown not to work in our cases. So actually all of these are negative currently. So the only deduction we can make from all of this pathophysiology is that we have a profound problem with organ perfusion. And if we take that through to what we can do about it, this is a key paper, and Joe's in the audience, first author of this, back from the Pittsburgh group, published in 1991, of children admitted to their accident emergency room, in the late 80s. And the cases were allocated to one of three groups, depending on the amount of fluid given in the first hour. Now, either less than 20 mils per kilo, 20 to 40, or more than 40 mils per kilo. And we can plot them out in a table as here. And so these are the three groups, low, medium, and high fluid, according to this amount given in the first hour. First thing to say is if you run the clock to 6 hours, the low groups stay behind the others. But the medium is almost caught up with the high group. So not a dramatic difference. That's not the interesting bit of data from this study. This is the interesting bit of data from this study. There's a major mortality benefit if you front load fluid resuscitation very aggressively to more than 40 mils per kilo in the first hour. There's all sorts of reasons we should doubt this study. It's retrospective, it's small numbers, but actually I can imagine that every bias that's working in this study would work against these patients, with the sicker patients being more aggressively resuscitated. So it holds true despite that potential bias. So the conclusion from that was rapid fluid resuscitation, 40 mils per kilo or more, improved survival, no increased risk of pulmonary edema. It just reminded me that that's almost exactly the same as Thomas Latter's conclusion from 170 years before. Not only it is unquestionably useful, but you don't see any bad symptoms from it. And similar data have been produced from the Brazilian group saying exactly the same relationship between the amount of fluid given in the first hour and mortality. So these observations have formed the basis for the consensus guidelines for hemodynamic management of septic shock. This is the 2002 version, but they won't be substantially changed in this regard in the 2007 version. So quickly recognise what's going on with the airway, etc., and then get on and give the fluid. And you should be giving fluid in 20 mils per kilo aliquots up to and over 60 per kilo. You might be lucky and they might respond to fluid, or you might be unlucky and they might need some more intervention with inotropic support and more monitoring. And any further care you need beyond that needs titrating to the clinical picture of hemodynamics you're faced with. What endpoints you should be shooting for is a sort of key element in this. And again, I think the recommendation that shock should be clinically diagnosed before hypotension by all of these signs. Interesting again that our case of cholera back in 1830 had all of these, altered mental status and altered temperature, cool extremities. But actually, perhaps the most important paper in all of these diseases we're talking about is from Emmanuel Rivers in 2001. And you can summarise this paper as looking for cryptic shock, looking for shock that's not clinically evident. And the key marker of this is the presence of central venous desaturation, where tissues are maximally extracting a limited cardiac output. We can't take you through the protocol other than to say standard care here was quite aggressive care. It was supporting central venous pressure, mean arterial pressure, and urine output. And the only change was to compare that with the intervention group, which was treating all of those, plus chasing a mixed venous saturation of greater than 70%. And it has the largest mortality benefit of any sepsis study. It's a 40% relative risk reduction from death, 46% in the standard group to 30% in the goal-directed therapy group. And again, you could distill this into the phrase that resuscitation to euvolemia, as you perceive it currently, is not enough. What we're saying is that, again, going back a few years, that Starling's law, you don't just fill to normal central venous pressure, you should probably be pushing beyond that, because that you can achieve more cardiac output, more oxygen delivery that is potentially useful. And again, data from Joe Briley at GOS, we think we're quite good at resuscitating shock, so it was a surprise to us to look back over the children who've arrived via our transport team who appear well resuscitated. The vast majority of them still have mixed venous saturation below 70%, regardless of the hemodynamics. These are unpublished data. Again, I'm grateful for these from Joe Carcillo. A Brazilian randomized control study comparing, following a very similar protocol to Rivers. Control group here, 40% mortality. When resuscitated to control endpoints plus a mixed venous saturation of greater than 70%, a very dramatic mortality effect. Okay, so treated mortality, 12%, relative risk reduction of 80% for death. And what's interesting is to drill into this data and just see what's done differently. What makes such a difference? Well, the main difference between the control group here and the intervention group here is that 20 mils per kilo more of crystalloid is given in the first 6 hours of care. That's pretty much it. There's a bit more transfusion, a bit more this and that, but this is the main difference, and it's very significantly different. And the other important bit of data from this study is that the patients are rescued from central venous desaturation. So in the control group, they measured the central venous sat, but didn't share it with the clinicians. And the mortality, if you were desaturated, was 70% in the control group. But you could be rescued from that down to the normal mortality in the intervention group. So these aren't predestined to die. It's not that they've got profound mitochondrial failure. So all of this pathology just tells us that we need to recognise early and give fluid. The simple clinical endpoints may not be enough, or if you want one line, more volume than you think. So finally, with a few minutes to go, I'm going to try and push on to the subjects I know less about and apply this where possible: dengue shock and severe malaria. Dengue, predominantly Southeast Asia, very clearly not in London. And perhaps if I was to skew this pathology, we might emphasise endothelial dysfunction, capillary leak more in dengue than the other components. But the resultant is the same: poor organ perfusion. It's spread by mosquito, biting an infected person, and then biting an uninfected person. They're particularly vulnerable if they've had previous infection. We classify severity according to grades of dengue hemorrhagic fever, with 3 and 4 being shock. And they're basically simple clinical descriptions based on the presence of adequate pulse pressure, plus the other findings common to dengue hemorrhagic fever. And what is great about it is that there are a number of large-scale clinical studies of fluid regimens in dengue. So here's one example, 230 cases from Vietnam, recommending relatively gentle fluid resuscitation compared to the septic shock we've just been talking about, but still very significant. 20 mils per kilo in the first hour for grade 3, and 40 mils per kilo in the first hour or so for grade 4. And what we should see, no real difference between each of the types of fluid you give, but all the children survived given this protocol, which should tell us something. Tex is an author on this paper from India, which rather than follow the World Health Organization guidelines, which are a little more gentle in terms of the amount of fluid being offered, basically make a comparison with the consensus guidelines for septic shock with more protocol-driven care for patients that are not fluid responsive. And this is a cohort study against using the World Health Organization guidelines in the late 90s, where there was a high proportion of hospital deaths, 17 out of 23, compared to the protocol-driven group in the 2000-2001, when the mortality was very significantly reduced. So from this pathophysiology, dengue, leading us to have some ideas about how we might manage dengue shock, we can feed back the comparative fluid studies which have not yet been possible in septic shock, and a validation of a structured approach to resuscitation have been achieved from this disease, which is not yet the case in many forms of septic shock. Malaria, then, again, notably absent from Western Europe. Perhaps the difference here, if we're going to skew our pathophysiology, is that anemia is a bigger part of the story. There's quite an interesting debate that I'm coming to for the first time about the management of malaria and the importance of acidosis in malaria. And Kath Maitland, who's here and will be talking next, I think, has done a lot of work in Kenya and can make a clear association between the severity of shock on simple clinical descriptions and the risk of mortality. And further, that the patients, regardless of the detail of their clinical situation in these three groups, exhibit a pattern of fluid-responsive shock with low CVPs coming up to normal and not shooting high, as you would expect if they were becoming hypervolemic. So this is the debate with reason on the left, and politeness forbids me commenting on the right, that the acidosis and shock results from hypovolemia and reduced tissue perfusion, and urgent volume expansion is the way to go. Or an answer where this is complex and perhaps it's mitochondrial dysfunction and aggressive fluid may be harmful. It seems to me that's a debate similar, and here's an example of that paper. We cannot advocate widespread aggressive volume expansion regimens because there's no evidence of physiologically significant loss of fluid in any of the compartments. I don't buy that. We've seen the benefit, both all the way back from Blalock, even latter, for giving supraphysiological volume expansion. The same argument has been applied to head injury, and we now, I think, all recognise the necessity of keeping an adequate circulating volume to maintain cerebral perfusion in head injury. So I'm not convinced, in my amateur's reading of malaria literature, that there's a case for gentle fluid resuscitation only. I believe it should be aggressive like all other causes of shock. And further, the malaria teams are also doing some of the comparative studies which we've struggled to do in paediatric septic shock, and we look forward to hearing more about that. So my summary slide then is that pathophysiology is complex, but the only thing that holds true in all scenarios is treating failed organ perfusion, and the mainstay of that is volume resuscitation. We effectively still believe Thomas Latter, 170 years on, unquestionable utility and not one bad symptom. That's my summary slide. And actually the same thing has been said by Joe Carcello and Rob Tasker, this catchy title, Fluid Resuscitation for Hypovolemic Shock, Acute Medicine's Great Triumph for Children, who point out that actually the same is true for all causes of shock over the last 40 or 50 years. Thank you.